In 3, 2, 1, we are live.
We are live.
He's going to say. He is going to say now.
Yeah, yes, sir.
We are live, sir.
Dear doctors from across the country, members of the noble profession, it gives me a very, very happy feeling to extend a very hearty welcome to you all today on behalf of Micro Labs and Micro Knowledge Academy. As you very well know, yesterday at the stroke of early morning 00 hours, a great thing happened in the sense that one of the best molecules, the king amongst the gliptins, the molecule, the gliptin molecule of the decade, was launched. And we, Micro Labs, as is our own, as usual, started off with a bang and introduced the molecule first in the market yesterday. And like always, we are educating and interacting with most of you learned doctors today with the allied faculty from across the country. We have with us Professor Dr. Ashok Kumar Das, sir, a very well-known figure, Dr. P.K. Jabbar, sir, Dr. Raju Chawla, Dr. Shashank Joshi, and Dr. Avdesh Kumar Singh. Welcoming everyone, and to give a more deeper information about all our faculty and also to start the program, I request Dr. Manjula Suresh, who is our Vice President Medical Affairs, to please start the proceedings. I also extend a hearty welcome to my colleagues who have really made this program the first program of sitagliptin happen today. Thank you.
Thank you very much, Srinath sir. Good evening, everyone. It gives me great pleasure and privilege to invite you all for this ADF National Seminar, which is Academic in Diabetics Forum. On behalf of Micro Labs and DTF3 and Micro Knowledge Academy, we thank you for accepting our invitation to render this state-of-art lecture in upcoming decision. Today's edition, we will be discussing about sitagliptin, and we call this session as Sitagliptin Conclave. As all of you know that last early morning, what Mr. Srinath told, we launched sitagliptin and it's made available across India. And as a practitioner, you would like to know the place of therapy, how to use it in practice, in the midst of so many gliptins, what's the place and what are the advantages. So we have planned a session to discuss all this and give you, our eminent faculty is going to share their knowledge and their experience, as well as going to give you some practical tips in your day-to-day practice. So therefore, I thank you all of you for joining in. As I have great privilege and a pleasure to introduce all our eminent faculty members. All of them do not require any introduction, but as it's a formality that I'm going to do. You can see the agenda. Initially, we have a very talk by each of our members of our faculty. They'll be spending 10-15 minutes time on each of the topic which you are seeing. Then there will be a panel. So to discuss this, I will be calling our post-director, Dr. A.K. Das sir, who actually does not require any introduction. Can I have the next slide, please? Though, as I mentioned, as a formality, I'll be doing so. Dr. Das is presently Professor of Medicine and Head of Endocrinology at Pondicherry Institute of Medical Sciences. Earlier, he was the HOD at JIPMER and Dean and Medical Superintendent at JIPMER Pondicherry. Sir has a very big passion of teaching. He has taught both undergraduate, postgraduates, and both in medicine and biology for more than 33 years. Even now, he is so interested. He is very happy teaching somebody. He is passionate about sharing knowledge and teaching, and he has more than 74 research papers to his credit and published in various national, international journals, and he has written chapters in several books. Dr. A.K. sir, A.K. Kumar Das sir, it's my pleasure and privilege to welcome you.
Thank you.
Have you as coordinator, sir. I will just hand it over and just I introduce all our faculty and then hand it over the session to you, sir. Now we have another eminent faculty with us, Dr. Avdesh Kumar Singh, sir. A.K. Singh, sir. Sir is a senior consultant endocrinologist at GT Hospital and Diabetes Institute at Calcutta. And sir has been the most sought after speaker. And if you see in diabetes or endocrinology, sir is always there as a speaker or chairperson of various panel discussion. Sir has written part of several books, as well as he's been editing various journals of endocrinology, to name a few. William Textbook of Endocrinology, Clinical Keys in Diabetics Endocrinology, Clinical Diabetology, World Journal of Diabetes, International Journal of Diabetes in Developing Countries. He's an ardent speaker, and he is also always there to share his knowledge. Dr. A.K. Singh, sir, welcome to you to the program. And the third eminent panelist we have is Dr. Shashank R. Joshi, sir. Sir is, all of you know, is a senior consultant endocrinologist at Lilavati Hospital in Mumbai. In fact, he was heading the COVID cell in entire Maharashtra. And Dr. Joshi is the president of Indian Academy of Diabetes and Endocrinology Society of India. Sir has been in various positions, and almost he's been heading many of our societies of physicians of Association Physician of India, Research Society of Study of Diabetes in India, which is RSSDI, and All India Association of Advanced Research in Obesity. Sir is involved in various activities of American Association of Clinical Endocrinology, and he has published several papers, and he's a senior editor of Endocrine Connections, which is a journal of European Society of Endocrinology. He's a prolific writer and has written several articles in diabetology, endocrinology, and has published more than 100 books and monograms, over 800 research publications to his credit, on topics such as diabetes, obesity, thyroid disorder, osteoporosis and growth. And also he is involved in a lot of patient education, public awareness activity. So Dr. Shashank Kumar Doshi, sir, it's a great pleasure to welcome you to, sir. Next, can I have the next slide, please? Now, Dr. P.K. Jabbar, sir is presently working as professor and head of Department of Endocrinology, director and CEO of Indian Institute of Diabetes at Trivandrum, Kerala, postgraduate teacher and principal investigator, and he has chaired a SICON 2017 and organizational person, organizing secretary of RSSDA 2020. He has also several credit as a level of publishing several books, chapters in the books, various textbook of medicine, has more than 35 papers in his journal to his credit, and presented paper in various endocrinology meetings, and regular examiner of various university and medical council inspector, and he is also DNB assessor. So Dr. Jabbar, sir, it's a great pleasure to welcome you, sir. We have Dr. Rajiv Chawla, sir. He's a trained diabetes and endocrinology center of Western New York, and he's a senior endocrinology and director of North Delhi Diabetes Center, New Delhi, honorary professor of Jaipur National University. He has several scientific achievements, and to name a few, he has been a teacher and guided students for more than 18 years, more than 65 papers on his credit, both in microvascular complication. He has authored 6 books, several oration awards. He was the immediate past chairman of RSSDI Delhi and organizing chairperson of RSSDI 2006 and 13, and also is a president of RSSDI, president of DPISA. So Dr. Chawla, sir, it's a pleasure and privilege to have you to the program. Welcome you too, sir. So with this, I now hand over the whole session to Dr. A.K. Akshay Kumar Das.
Thank you, Dr. Manjula, for this
over to you, sir. Thank
wonderful
you.
opportunity given. I'm delighted beyond measure. Now, today is a very important day in the history of diabetes management in our country. In the hierarchy of oral anti-diabetic management, it is today that we are going to speak about something which is, I'll just start sharing my screen. We are going to talk about something which is of a great value and which has a great thing to happen today, and we are going to discuss about that. Can I make it full screen, please? Can I make it full screen? I'm not able to make it. I'll make it now.
Yeah.
Yeah. Dear friends, I must mention here that in the hierarchy of oral antidiabetics, the gliptins, I consider, are the drugs of tremendous importance. And today we're going to discuss regarding one such molecule, which is available today to all of us from midnight of 6th as the gliptin molecule of the decade. And I speak few things by way of introduction. Dear friends, to make a long story short, we have many pharmacological interventions for type 2 diabetes, oral interventions. But the drawbacks are many and several of these interventions do suffer from two things. One is hypoglycemia and weight gain. And these two have limited our using these drugs for the cause of diabetes. Now, there are drugs today available in our armamentarium. They target the incretin pathway, and they're one of the latest additions to the available anti-diabetic drugs. These are the incretin-based therapies we're going to discuss today from the eminent experts. They're either given injectable one, which is little difficult in our setup, like the injectable GLP-1 mimetics. We call it incretin mimetics, to be given subcutaneously injected. But what is most important, readily available, easily to be taken, is orally dipeptide peptidase DPP-4 inhibitors. And they are the drugs which has made a great change. Dear friends, the pathogenesis of type 2 diabetes started with two things: beta cell exhaustion and insulin resistance. Today, from the divariate, it has gone to trivariate, where we have got this issue of incretin effect. Lo and behold, with the advent of this particular group of drugs, the incretin mimetics, these are the injectables, and incretin enhancers like sitagliptin, molecule of the decade. This incretin effect has been corrected, and this has greatly helped in taking care of the hyperglycemia and various other pathophysiology, morbidity of type 2 diabetes. Dear friends, the incretin effect in the healthy subject is shown here. You find that the rise in the C-peptide as an incretin effect with the oral glucose is huge, whereas in intravenous, it is not that huge. And if you looked at the type 2 diabetics, to make a long story short, there is a diminished incretin effect compared to the normal incretin effect in the normal individuals. So this is a great issue which has been addressed by this drug. Therefore, the patient type 2 diabetes mellitus incretin effect is greatly impaired or absent, and it is assumed that this could be responsible for the insulin secretion in the people. This is a famous slide of the ominous octet of the DiFranco, and I'm just showing it because many of my speakers might refer to it. But to make a very brief mention, 5 out of this ominous octet, I'm telling 5 out of the ominous octet are addressed by this molecule of the decade, the sitagliptin and other gliptins. And we'll be discussing it, how various permutation combinations, especially this gliptin, sitagliptin combined with gliflozin, say dapagliflozin, can make change which almost equal to oral semaglutide. Dear friends, we have 2 incretins, the GIP, I'll not discuss in detail. This is the introduction. We also have the GLP. GIP is very difficult. It's a less attractive therapeutic target, but the GLP is the most attractive therapeutic target. And there are GLP receptors in the islet cells, and GLP metabolized by the enzyme DPP-4, which makes it available. GLP and the GIP both are synthesized and secreted from the gut in the response to food intake. And this GLP molecules has numerous functions in the humans. Number one, on the ingestion of the food, GLP-1 is secreted. They promote satiety and induces appetite. They act on the alpha cells by decreasing glucose-dependent postprandial glucagon secretion. They act on the liver, reducing the glucagon hepatic glucose output. They work on the stomach, helping to regulate the gastric emptying. And most important, they act on the beta cells, enhancing the glucose-dependent, no hypoglycemia, glucose-dependent insulin secretion. Therefore, sitagliptin was approved by the FDA on the October 17th of 2006. 2007, on the April 2nd, it was the combinations were approved, starting with sita plus metformin. Now, it is the first DPP-4 inhibitor. Therefore, the longest experience. I'm extremely happy that we have got this molecule in the armamentarium today. It is approved in the treatment of type 2 diabetes in various ways as a monotherapy, in less occasions as a second agent in those who do not respond to a single agent, such as SU, metformin, or thiazolidine, or as a third agent when the dual therapy do not deliver the goods. Now, the mechanism is to increase incretin levels, which inhibits the glucagon release. And this glucagon release inhibition can increase insulin secretion, decrease gastric emptying, and decrease blood sugar levels. Dear friends, DPP-4 inhibitors are effective with a very low, almost nil incidence of hypoglycemia and no weight gain, either when it is used in singly or in combination therapy. The glycated hemoglobin comes down, the fasting and the PP glucose come down. The glycemic efficacy has been shown in many studies. I will not show those slides. The usual dose of sitagliptin is 100 milligram once daily. Can be reduced to 50 milligram whenever necessary, especially when there is a renal insufficiency. When the GFR drops down to much lower, it can be even 25 milligram. The glycemic efficacy has been demonstrated in the various studies. In one of the studies, the HbA1c came down from 8.1% by 0.6. In various other studies, it has been shown to come down up to 0.8, 0.9%. In combinations, it has also produced wonder in bringing down the HbA1c, PPG, and the FPG. To end, I must mention here, it works in response to a meal, the DPP-4. Active glucagon-like peptide 1 is secreted by the L cells of the intestine. Without the presence of the gliptin, GLP-1 gets rapidly inactivated and degraded by the enzyme dipeptide DPP-4. When a gliptin is present, it binds to DPP-4, allowing the GLP-1 to remain active. An active GLP-1 causes the pancreas to increase insulin release and decrease glucagon release. So the mode of action is enhancing meal-related insulin secretion, glucose-dependent, in a glucose-dependent manner, restore the fast-phase insulin secretion, which is RA in the type 2 diabetes, first to be affected, and suppress inappropriately elevated glucagon secretion, regulates gastric emptying, reduces food intake. There are some studies, there are doubts that totally not yet cleared, but I'm just flashing the issue. There are increase in beta cell mass in the animal models and improved beta cell function. The DP4 inhibitors inhibit DP4 activity, thereby slowing the rate of endogenous incretin hormone degradation and facilitating their glucoregulatory function, like improving meal-related insulin secretion, suppressing inappropriately elevated glucagon level, and increase possibly, I'm adding the possibly beta cell mass. Now, you know, the majority of the type 2 diabetic patients are not at HbA1c goal. Now, only 48% are not in the United States. India, almost about 70%, various countries are shown here. And one of the reasons why clinical inertia is among the physicians because of our fear of hypoglycemia and weight gain, which is not there in this molecule sitagliptin. There are a few other benefits which we'll discuss in the question answer session. I must stop here and say that there are some studies in gliptins. It has been shown sitagliptin in particular, and in focus, has increased beta cell mass and decreased alpha cell mass. The diagrams are given here compared to glipizide over 10-week period. There are also studies that chronic sitagliptin treatment can normalize islet cell morphology. Dear friends, therefore today in the state of the nation, I like to mention the main treatment barrier to sitagliptin was a little bit of non-practical pricing from our country point of view. It is all relative. Number two, it was not easy to afford, and there were public health barriers about distributing this drug across the country. However, the complexity of the drug and the cost of the care have been addressed since last night. Today, therefore, the generic sitagliptin has become the gliptin molecule of the decade because of its 4 A's. It is now affordable, and you will see from the experts, it's the most appropriate drug to be used. It is available across the country and easily accessible. Dear friends, it's my great pleasure and my great honor now to invite someone whom I love, whom I adore. I love my younger brother. I'm simply astonished by his command over the subject. The way he delivers the science the easy way of its approach and making things crystal clear. Dear friends, today we have amidst us Dr. Abdes Kumar Singh. He has been introduced right royal manner. I just say a single word. I don't mince words. He is one of the greatest scientists and medical educationist and medical researcher and reviewer of the globe and our nation today. And I present to dear friends this great person, Professor Dr. Abdes Kumar Singh, to speak to us. The glyptins in the era of the glyphlogens. Dear friends, let us all listen to this phenomenal speaker, Professor Abdes Kumar Singh.
Thank you, sir,
Abdes, thank you.
for the kind word. Thank you, Microlabs DTF. Good to see everyone on the board. So, always a pleasure to share my thoughts with the great people in the panel. Now, so coming back to this particular issue of so sitagliptin is there for a long time, and what we are today doing is that the innovator has lose their patent, and Indian pharma company has come up with generic sitagliptin market. We are reviewing this drug for past 15 years or so. Remember, this drug was approved in 2007 by US FDA and was brought in US market in 2008. It's a long story. What we are trying to suggest that where does this molecule DPP-4 inhibitor as a whole and sitagliptin in particular is there in the current SGLT2 era? Remember, all the guidelines in the world recommend SGLT2 or GLP-1 in patients who had established heart disease, heart failure, and chronic kidney disease. Therefore, and also, if you see the guidelines, ESC or EASD 2019 guideline, they recommend SGLT2 inhibitor as a first-line drug, putting metformin as a second line. Therefore, we are absolutely in the SGLT2 era, and it's absolutely correct because we have generated evidence with SGLT2 that it protects heart and the kidney in patients with type 2 diabetes. Therefore, is the DPP-4 inhibitor in SGLT2 era? That's the point I'm trying to make here, and we'll look into where the sitagliptin in particular is placed. Let me take you quickly through this paper. This is a perspective published way back in 2007, and it was written by David Nathan. You know what happened? This is a long story. Many people may not be aware, and thus I thought to show you this particular NEJM paper published in 2007. And David Nathan wrote that how sitagliptin was approved by US FDA. Right? This is very interesting data. You can see here, I put it in a highlight mode. What is surprising is that despite the paucity of published data from long-term clinical trial, sitagliptin was approved by the FDA. This was published in NEJM, remember. And why Nathan, complained about giving approval of sitagliptin by US FDA? Because US FDA hurriedly gave the approval of sitagliptin based on only one trial. At that point of time, 3 more trial was in progress. However, sitagliptin never looked back. And, if you look at the brand Januvia that lost patent in India yesterday at the midnight, they earned 3,000 billion rupees with Januvia cell itself. This speaks volume as to how sitagliptin landed into the market with a, fan follower everywhere in the world. Now, in the SGLT2 era, where does we place DPP-4 inhibitor, or in particular sitagliptin, with the mammoth evidence generated by SGLT2 inhibitor? So I had a privilege to write this interesting paper in the current issue. If you go to the World Journal of Diabetes, I wrote this paper, keeping in mind that the generic DPP-4 inhibitor will bombard in the market. And we need to know that where is the DPP-4 inhibitor in the era of SGLT2 inhibitor? Where should we put this molecule? in the current hierarchy of treatment of diabetes, given the mammoth benefit in terms of reduction in heart failure, hospitalization, and protection of kidney by SGLT2 inhibitor. Ladies and gentlemen, please remember that there is no doubt that SGLT2 inhibitor is a wonderful drug in patients with established cardiovascular disease or a background heart failure or a established chronic kidney disease. However, when it comes to glucose lowering in patients who do not have those risk factors, the DPP4 inhibitor still has a lot of role to play. So that's why I thought to review the evidence, what happened in past 15 years with DPP4 versus SGLT2 inhibitor. And let me show you interesting facts in front of you. Many of you may have perhaps believed that SGLT2 is a very powerful drug, whereas DPP4 inhibitor has got a only modest HbA1c reduction. Now, if you look into the head-to-head trial, till date conducted between SGLT2 and DPP4, you can see there are 7 trials in front of you that compared SGLT2 with DPP4 on a different background treatment therapy, and that varies from 12 to 90 weeks with a different baseline category. And you can see the gold standard DPP4 inhibitor, sitagliptin, was compared with various SGLT2 inhibitors. Now, if you look at the HbA1c drop between SGLT2 and DPP4, you would be surprised that there was no difference in HbA1c reduction between SGLT2 and DPP4. Barring, if you look here, superfix A, which suggests that drug A with SGLT2 is better than drug B, DPP4, only in a rare circumstances, like in this 2 trial, where Cana 300 milligram was compared to sitagliptin 100 milligram, the Cana 300 milligram was found to be superior. And there is no rocket science. Cana 300 is a completely different SGLT2 inhibitor. Remember, Cana 300 is not a SGLT2 inhibitor. It is a SGLT1 plus SGLT2 inhibitor. Whereas Cana 100 milligram is only SGLT2 inhibitor. And therefore, the Cana 300 milligram has to have a better HbA1c lowering compared to sitagliptin. Therefore, barring the highest possible licensed dose of Cana, other SGLT2 inhibitor was as good as sitagliptin 100 milligram. And in fact, IMPA 25 was also compared with sitagliptin, and there was no greatly statistical difference in HbA1c lowering. So these are head-to-head evidence that suggests that you cannot write off DPP4 inhibitor when it comes to glucose lowering. Yes, SGLT2 is a wonderful drug when it comes to protecting heart and kidney, but when it comes to controlling blood glucose, DPP4 is as good as SGLT2 inhibitor. Now, if you look through the lens of meta-analysis done with all the trials, you can see here again, I tried to compare, SGLT2 versus DPP4 in glucose lowering. There is a hardly minuscule difference in HbA1c lowering between SGLT2 and DPP4 inhibitor by maybe extra minus 0.1%, which is clinically not meaningful. So therefore, if you look these meta-analysis, you can see 5 meta-analysis in front of you that suggests that hardly there is difference between SGLT2 and DPP4 in terms of HbA1c lowering. If at all it is by 0.1%, which is not clinically meaningful. Now, so where to use SGLT2 and DPP4 in clinical current practice when it comes to glucose lowering? We also looked into where to prefer DPP4 over SGLT2 inhibitor. And nobody will tell you, where the DPP4 may be better than SGLT2 inhibitor in glucose lowering. And here is the example in this paper. We dissect it out clearly how DPP4 inhibitor can be more utilized compared to SGLT2 in bringing down HbA1c. If you look into this 3 trial that compared SGLT to DPP4 stratified on baseline HbA1c, say more than 8.5% or less than 8.5%, you would be surprised to see that if the patient baseline HbA1c is less than 8.5% or 8%, then DPP-4 inhibitor lowered HbA1c better than SGLT2 inhibitor. And this is amazing. Look here, sexagliptin 5 milligram 0.69, Depart 10 milligram only 0.45 if the HbA1c is less than 8%. Isn't it surprising? And I wrote in this paper why it has happened. However, if the baseline HbA1c is higher, the SGLT2 outsmarts DPP-4 inhibitor. So more is the baseline blood glucose, higher is the glucose drop with the SGLT2 inhibitor. And just opposite, modest is the baseline blood glucose, the DPP-4 inhibitor, more powerful drug than SGLT2. And didn't happen once, it happens thrice. Look into the second trial. Look here, linagliptin 5 milligram versus IMPA 10 milligram. Looks that is a pretty good DPP-4 inhibitor. Now, look this paper, less than 8.5%, linagliptin 5 milligram 0.62, IMPA 10 milligram only 0.46. This clearly hints that if the baseline HbA1c is modest, say 8.5 to 8%, then DPP-4 inhibitor works wonder, perhaps better than SGLT2 inhibitor. That's the point to note. But then again, if the baseline HbA1c is higher the baseline HbA1c, larger is the HbA1c lowering with the SGLT2 inhibitor. That's the glucose lowering ability of a DPP-4 inhibitor, which cannot be ignored. And at the top of that, please remember that SGLT2 inhibitor loses its efficacy with a declining EGFR. So lower is the EGFR. If the EGFR is less than 45, SGLT2 is not a wonderful drug in terms of glucose lowering. Yes, it is a wonderful drug in terms of protecting kidney, but at the end of the day, we need to control blood glucose as well. And therefore, SGLT2 alone will not work if the EGFR is less than 45, and DPP-4 works regardless of baseline EGFR. It works similarly regardless of the EGFR. These are the two areas where still DPP-4 goes up in the ladder over SGLT2 inhibitor. If there is a modest baseline HbA1c, DPP-4 will reduce HbA1c better than SGLT2. If you have got a CKD, the DPP-4 inhibitor lowers HbA1c far greater than SGLT2 inhibitor. It's the only 2 point, remember, where DPP-4 inhibitor outsmarts SGLT2. Otherwise, in every circumstances, SGLT2 outsmarts DPP-4 inhibitor. Now, look into the different DPP-4 inhibitor quickly. So because of paucity of time, and when I'm presenting this, you have a faith on me, and Sasank is here. We have launched Januvia in every part of the world, and perhaps both of us has delivered more than 10,000 talks for MSD for the Januvia launch. And I know every details of these data, how many trials has been fought between sitagliptin with other DPP-4 inhibitors. So to summarize about the HbA1c lowering ability of sitagliptin, remember sitagliptin was fought with all currently available DPP-4 inhibitor in India versus vildagliptin, it is similar. You might see in many seminars that some speaker shows you some data where vildagliptin was found to be better fasting glucose lowering and better glycemic variability lowering drug. But I will show you another few papers where sitagliptin shown a better efficacy than vildagliptin in terms of glycemic variability. Therefore, I would give my judgment that in terms of glucose lowering, all the DPP-4 inhibitors are more or less same, right? So you look into the Sita versus Sexa, majority of trial found it similar. Sita versus Lina, majority of trial found it similar. Even tenaligliptin fought with sitagliptin, and it was found. The evogliptin fought with sitagliptin and was found. Oh. Please mute yourself. Okay then. Finally, I will take you through the cardiovascular safety. I am sure Sasank is going to tell you in detail. These are the cardiovascular outcome trial. We followed it since 2013 when the SABRE-TIMI trial was presented at ADA. Same hall examine was presented. We all were live present in all these trials. They looked for the cardiovascular safety of DPP-4 inhibitor because of US FDA mandate given in 2007. The TECOS was, exception to the rule that sitagliptin MSD started their, cardiovascular safety trial even before US FDA asked them to do so. Exactly one day before the US FDA asked every pharma company to conduct cardiovascular safety outcome trial. The difference is that the TECOS trial of sitagliptin had a primary objective of 4-point miss, unlike other trial where it was 3-point miss. You can see even in Carmelina, it was initially planned to have a 4-point miss, but Boehringer people were very clever. When they found that TECOS was neutral, they deducted one endpoint and they become 3P miss. Many of you may not be knowing that it was actually a 4P trial, which was later on changed to a 3P miss trial. The Carmelina was, the linagliptin trial was one exception in the form that they tried to establish linagliptin as a renal, positive molecule, and they put renal outcome in the secondary endpoint, which other trial did not have. If you look back, Sabertimi, Examine, and TECOS. So that's the difference in Carmelina, that the renal endpoint was a secondary objective trial. Now, if you quickly look into what happened in these trials, you can see that basically they came neutral on the primary objective. If you look at the 3-point miss of all the trials, the TECOS has 3-point miss as a secondary outcome. It was a 4-point miss trial. So it came absolutely neutral. This suggests that these DPP-4 inhibitor approved by US FDA are cardiac neutral. Very simple. Whereas in the Carmelina trial, when they looked for the renal outcome, it again came neutral. They did not find anything good, neither they found anything wrong with linagliptin in terms of kidney protection. Therefore, if anybody could try to convince you linagliptin protects kidney, just quickly grab hold of them. The gentlemen, there was no data in the Carmelina that find linagliptin to be superior in protecting kidney. So where from this noise is coming, that I will show you just after this slide. So this is the result. Primarily, all this trial neutral, except there was some signals of increase in heart failure, which was highly statistically significant in the Sabertimi trial. There was 27% increase in heart failure hospitals. Some signal was also seen in allogliptin in Examine. And therefore, US FDA put a black box warning in both sexagliptin and allogliptin. For allo, it was unfortunate because it wasn't a statistical significant. But because of prohibitory law in United States, US FDA put warning to all DPP-4 inhibitor, in fact, not to be used in patients with heart failure, but they put a black box warning on sexagliptin and allogliptin, which still exists, including in India. Please remember, there is a black box warning in Europe as well as in India with the sexa and the allogliptin. Neither sita nor linagliptin, which came neutral on heart failure outcome, has got any black box warning in India. Therefore, if you are using sitagliptin or linagliptin in patients with heart failure, it's absolutely fine when it comes to the PI from the Indian DCGI. Now, sometimes people ask me, the Carmelina was conducted in patients primarily with kidney disease. You can see here majority of patients had CKD, whereas the TECOS had very less patients with CKD. Therefore, Carmelina stood the time because they had a sick patient. That's a wrong information. Please remember, in the TECOS trial, everyone had a cardiac disease on sitagliptin, whereas in Carmelina, majority of 60% of patients had CKD, but only 57% had heart disease. So if you combine both heart disease and kidney disease in terms of sickness of the patient, including heart failure, the TECOS trial had much more sicker patients, including heart disease, including kidney disease, including heart failure. And therefore, let's not get into trap by simply suggesting that Carmelina had more sicker patients than the TECOS trial. That's not true. Yes, in the Carmelina, more patients had CKD. But in the TECOS, everyone had heart disease, which the Carolina didn't have. Then in the TECOS trial, majority of patients, means higher the patient, had the baseline heart failure compared to Carmelina. And very important, there was no Indian patient in the Carmelina trial. So we are extrapolating Carmelina data into the Indian patient, whereas in the TECOS trial, more than 1,000 patients were from the India. I was also the investigator for the TECOS. And therefore, there is a difference when it comes to the TECOS and Carmelina when you are trying to differentiating between sitagliptin and linagliptin. Finally, people will keep on telling you, see, there is a data which suggests that linagliptin reduced albuminuria by 14% in the Carmelina trial. This was an exploratory endpoint. I have shown you in the secondary objective, reduction in albuminuria was not the endpoint. This was the renal composite. Sustained ESKD, 40% eGFR drop, and renal death. Albumin was exploratory endpoint. And what if a drug reduced albumin by 14%? Is it a kidney friendly or a kidney protecting drug? No. Reduction in albuminuria is a soft surrogate endpoint. You have to reduce the kidney endpoint, hard kidney endpoint. And please remember, it was not only seen in Carmelina. You are befooled by the pharma company. I will show you. In the Sabertimi trial, they have got the best data in terms of reducing albuminuria. Look here, see the p-value, whether it is worsening albuminuria or improved albuminuria. Sexagliptin has got a best albumin reduction data. Unfortunately, despite albumin reduction, there was an increase in heart failure. So I don't need a drug that reduces albumin, but increases heart failure. And look here, there is a proof to this proof of concept. There was a double-blind trial called DELIGHT. It was done with dapagliflozin and dapagliflozin with sitagliptin on an albumin reduction endpoint. You can see the blue one is the dapagliflozin here, and the red one is dapa with sexa. There was a clear signal that suggests adding a sexagliptin to dapagliflozin further lowered albumin, albuminuria reduction. Thereby, if you are looking into the albumin, the sexagliptin has got best data. Unfortunately, there was an increase in heart failure. So despite some theoretical proposition of kidney protection, there was increase in heart failure. What about sitagliptin? Many people doesn't know. SABIT, this was presented in ADA when I was present. It was presented by Rory Holman. It is not anywhere present. Even in the TECOS trial, there was a reduction in albuminuria. Look at this graph. Look at the p-value. Therefore, if the linagliptin people claims that they are the only drug that reduces albumin, it's incorrect. Both sexa and sita. Even in the allogliptin trial, I have got the data. I am not showing you because nobody used allogliptin. They did reduce albumin. But ladies and gentlemen, reduction in albumin is a soft surrogate. This didn't suggest anything in terms of protecting kidney. So they are renal friendly drug, but they do not in fact reduces CKD through any trial that we looked into Carmelina. Finally, the TECOS was unique in three sense. Look here, the TECOS was the only trial with sitagliptin that clearly looked into elderly data. This is a TECOS data in elderly more than 75 years of age. Remember, the DPP-4 inhibitor is the drug of choice in elderly population. And if you look sitagliptin in particular, this is absolutely on the dot. So this suggests that there is no harm whatsoever with sitagliptin in elderly population. This is second proof of concept through the TECOS, that in the TECOS trial, and you can see there was a clear proof that in ASEAN, the DPP-4 inhibitor works wonder. And this is the TECOS data. You cannot have a better data than the TECOS trial, which was conducted for 3 years. And this showed that still in a glycemic equipoise trial, there was a better glucose control with sitagliptin in the Asian population. And finally, which many people is not aware, there was one positive signal from the TECOS trial, which nobody knows. Look here. If you look into the TECOS trial, although it was a neutral trial, but in the female arm, there was a benefit. This is the female population data. There was nearly 4,000 women in the TECOS trial. And if you see the 3-point mesh or 4-point mesh, there was a good reduction. Although this is, I would say, from the statistical point of view, it is a hypothetical, but there is some evidence that suggests that sitagliptin can be a wonderful drug in women, and it came through the TECOS. That's the very interesting evidence. And look, this Kaplan-Meier curve in female, if you look into the primary endpoint, or if you look into the death, female was saved through the sitagliptin compared to the placebo in the TECOS trial. So this is one positive endpoint which came in the TECOS trial with sitagliptin, who nobody is aware about. And finally, if we look into the TECOS trial, there was another interesting finding that the all-cause hospitalization was less with sitagliptin compared to placebo, which was seen after 2 years. You can see this KM curve separating at 2 years. Thereby suggesting that sitagliptin is absolutely neutral. They do not put you in anything wrong, and you have a less chance of getting hospitalized if you are on a sitagliptin or DPP-4. Finally, when it comes to the heart failure, we did meta-analyze, you can see 3 years back, and looked into after the Carmelina. We didn't find any signal with heart failure if you combine the entire data of all DPP-4 inhibitor cardiovascular outcome trial. In fact, we wrote a letter. You can see me and Samit did a meta-analysis and wrote a letter to US FDA. Why are you putting a level of heart failure when you have got no evidence through all the trial? We added into Omarigliptin Omnium trial, and we suggested there is no signal of increase in heart failure with DPP-4 inhibitor. And if you look into the guideline, if you see the ADA ESD guideline, where is the DPP-4 inhibitor? If you have got established cardiovascular disease, choice is GLP-1 or SGLT. What next? You can see here, they said, go for the DPP-4 inhibitor if your patient is not able to afford a GLP-1. What about heart failure? Look here, this is very fascinating data. If you have got a patient with heart failure or CKD, the SGLT2 is the first line. Then you add GLP-1. What if the patient cannot afford GLP-1? Clearly, the ADASD said go for a DPP-4 inhibitor barring sexagliptin. Very clear. That means ADA-ESD has allowed you to use a DPP-4 inhibitor other than sexagliptin if you have got a patient with heart failure or CKD, but use SGLT2 as the first drug after metformin, and then you can add DPP-4. Finally, if you see the ESC guideline in patients with heart failure, both sita and linagliptin has been put to the front with a class 2B level B evidence that you can use these two DPP-4 inhibitor in patients with heart failure as well. So, ladies and gentlemen, quickly take you through this glimpse of what I talked in last 15 minutes. When it comes to HbA1c lowering, perhaps all are. But when it comes to cardiovascular neutrality, only these 4 drugs had stood out of time. That's very clear. Heart failure hospitalization, only we found signals with the sexagliptin, so we cannot consider as a class effect. Now, when it comes to albumin excretion, which linagliptin claims that it is only with the Carmelina, with linagliptin, that's not true. I have shown you the SEBER data, I have shown you the TECOS trial, both the sexa and sitagliptin also showed albumin reduction. That's not a rocket science. Reduction in albuminuria not always protects kidney. Now, when I have to choose between a DPP-4 inhibitor, of course, sita and lina will come into the front. But if I have to again, make a fight between sita and lina, perhaps sita has got some edge in my mind. Looking into all the evidence put together, I would always opt for sitagliptin given the opportunity, and with the availability of the generic sitagliptin, which is perhaps 1/5 cost of linagliptin. Now the choice is clearly sitagliptin. Neither Vilda nor Tenali or evogliptin have got any cardiovascular safety data. I don't use it. Very simple. Thank you very much for your patience.
Dr. Das, you're muted.
The masterly presentation, Sasank, with lot of new points, lot of clinical, practical points, which are very important from our point of view. We'll have a discussion. I now invite Professor Dr. Shashank Joshi to speak on the clinical positioning of sitagliptin in our country. I have no words to introduce Shashank. He's my younger brother. I must tell you that he has exceeded in every field that he has treaded, and in every field that he has taken over in his hand. And today he has got the capacity to speak, to write, to convey the last word on any aspect of diabetes and endocrinology. And it's my great pleasure and honor to invite Shashank. I will not eat up on his time to speak to us regarding Shashank, to speak to us for your full time regarding the clinical positioning of sitagliptin in our country today. Over to Shashank. Shashank, all is yours.
So thank you, Professor Das. I think my good friend, Professor Udesh Singh, has actually made everything very clear. So I don't know whether I should use any slides or just do a dialogue, because Udesh has given a very evidence-based approach on the molecule. He gave an overview of gliptins in SGLT2 era. He also told us that gliptins are a standard of care, and I would take it further from there. And I'm sure everybody will agree that among all the gliptins available on planet Earth, the first gliptin to be approved, though not discovered, on planet Earth was sitagliptin. Vilda did not make the cut to the US because the 100 milligram OD dose had a liver issue. They submitted their dossier thrice to the US FDA, but they faltered. So they obviously never got that approval. The sitagliptin not only was launched first, but sitagliptin metformin that time in 2006 when it was launched had an A1C reduction of 3.8%. More the carbohydrate, the better is the drop. The third thing is that if you look at PubMed, and Dr. Avdesh Singh is very active on evidence-based medicine, Dr. Das is active, I am active. I can see my good friend Dr. Jabbar here, Dr. Chawla is here. Clearly, we can see that it is the most evidence-based gliptin till date. If you do a PubMed search, it is the largest published gliptin till date. So, that is something which is very clear cut. So Avdesh has already set the ball rolling. So some of my slides might sound repetitive, but sitagliptin is standard of care. Among the gliptins, if I have to pick up one, Avdesh made my job very simple, that among all of them, it is CV safe, it is renally safe. He also bust the myth about Lina's renal quasi-safety and quasi claims in a very scientific and evidence-based way. So a lot of, under the table marketing also he took it away, that it is not a renal gliptin. You can dose yourself at 25 and 50 milligram of sitagliptin and it is equally renally safe. In fact, sitagliptin has more renal data than linagliptin. If you just look at the deep dive of scanning it. So I am going to maybe just present a few slides because of this, as I said, made my job very, very easy. Where do we look at it? And I'm just telling you some simple points. That ease of administration, once a day, simple administration, it is meal independent. So sitagliptin is once a day, meal independent, minimal drug interaction and drug metabolism. If you see, linagliptin has a lot of drug interaction, drug metabolism, anti-TB drug, anti-conversion drugs have a lot of challenges with linagliptin. It is well tolerated in everybody. It competes for adverse events with placebo. It has the broadest range of patient profile, from pre-diabetes to diabetes to fatty liver to even people with type 1 diabetes, they have data on sitagliptin. So it's the most broad range gliptin with evidence base, though these are all off-label, many of them, those uses. And it is irrespective of any background category, whether it is kidney, liver, heart. It has the best durability. If you look at the coefficient of failure with minimal secondary failure, and the glycemic variability is the lowest. And as I said, it has minimal or hardly any, challenges, except for maybe some allergic rhinitis or occasional allergy. It is quite easy. And it is also easy to use sitagliptin or Januvia or, the original compound which was there in sick day management. So even in the COVID space, it had some excellent data. It was probably the most evidence-based molecule because, that they had generated retrospective and prospective data both. So gliptins clearly are simple agents. They don't need any dose titration, particularly sitagliptin. And you can clearly see that they are meal independent. They are meal independent. Again, Vilda has a challenge there. And as far as sita goes, compared to all other gliptins, it is minimally metabolized. Sita is renally rooted. So you just drop the dose down if the creatinine clearance is down. And there is no challenge with the hepatobiliary involvement. And, if you look at drug interactions with the various other common oral anti-diabetic agents, sitagliptin is having no clinically meaningful drug-to-drug interaction. So that's really the thing. Other gliptins do have it. And, except for maybe it doesn't have any boxed warning or contraindication like all other agents have. So it's a no-brainer. A general practitioner can use it, a primary care doctor can use it, a nurse practitioner can use it. Anybody can use a gliptin like sitagliptin. So obviously, when you combat warnings and precautions, there is no major challenge. It does not cause any hypoglycemia. Neither does it cause any weight gain. That data is also very clear cut. Of course, if you use it with a sulfonylurea or insulin, there may be a hypoglycemia. There were some post-marketing anecdotal reports on acute pancreatitis, but now we know the verdict is out that more than 200 molecules cause acute pancreatitis. You need more than 1 or 2 risk factors. There were reports of acute renal failure. There were reports of allergic and hypersensitivity reactions. There were reports of some substance P of severe arthralgia and disabling arthralgia and bullous pemphigoid. But clearly you see that the gliptin space, sitagliptin among all these reportage is the lowest. So with the liver concern, it is none. CKD concern, it is none. Drug-to-drug interaction, it is none. QT prolongation, it is none. It is the most super selective gliptin. It doesn't have any increase in uric acid, which linagliptin increases uric acid, as we all know. Again, on amylase lipase, it has no data, which linagliptin increases. And on interstitial pneumonia, there is no data. So if you see, it is all green gliptin. It's a green gliptin, I call it. All other gliptins have something or the other where they falter. While when it comes to overall safety and tolerability, sitagliptin scores out clearly. I won't go into this slide because Dr. Avdesh told us so beautifully that this is a CV safe gliptin. So ADA-ESD algorithm now says that this is okay. It doesn't aggravate any hospitalization of heart failure. The upper bound never caused the confidence interval with TCOS on any specified endpoint, and it's durable. It improves the beta cell apoptosis, and it has efficacy across all A1C baselines. So you can see head to head, sitagliptin is efficacy comparable to all other classes of anti-diabetic agents. You see whether it is head to head with metformin, sulfonylurea, pioglitazone, voglibose, it has data across board. It is at par. And because we eat more carbohydrates, the more carbohydrate a patient eats, the better is the A1C drop. And clearly the data is not just against the standard agents, but on A1C lowering, it has head-to-head data for 1 year across canagliflozin and empagliflozin also. So here you can see data head-to-head Sita 100 versus Cana 100, 0.73 A1C drop, as well as EMPA versus Sita, clear again 0.66 the A1C drop. So head-to-head data exists, and this is standard published data. When it comes to the renal gliptin, you can see here it's all green again. Again, it's a very, very green gliptin, no brainer. You can just use it very comfortably. You just need to drop the dose. And it has very good, robust science, both from Scott et al.'s paper as well as Wu et al.'s paper, that the composite R trials showed that sitagliptin was significantly more effective and better tolerated in than dapagliflozin with mild renal impairment. So that data is also available. You can see a head-to-head data, Sita versus Depa with a delta of 0.15. And again, the achievement of A1C targets, Sita versus Saxa, much more there. And you can see durability is across the 3 doses of sitagliptin, 100 milligram, 50 milligram, 25 milligram. So the A1C drop is persistent and consistent. So really it is a very, very renal safe gliptin. And even 7-year data, long-term outcome data with sitagliptin shows that it is very, very robust. This is Derosa's study published almost 4 years back, clearly showing that it is a decades gliptin, works very well. And it has the least marge or the mean amplitude of glycemic excursions. So again, sitagliptin has that data in RCTs to show that it has less of glycemic variability. So I think I'll stop here. As I told you, sitagliptin has its place as a standard of care. What Dr. Avdesh told us and what Dr. Das started, that gliptins are standard of care. They clearly are across the world replacing sulfonylureas because sulfonylureas cause weight gain, they cause hypoglycemia, and their CV safety is not established beyond reasonable doubt. As far as sitagliptin is concerned, it is the most evidence-based gliptin in the gliptin class. It is a hassle-free gliptin, whether it is renal, liver, or cardiovascular entity is concerned. So there is no major challenges with that at all. It can be used any time of the disease, whether it's early disease, middle disease, late disease. It can be used with high A1C or low A1C. Does not cause hypoglycemia or weight gain. So it's a very, very safe and an effective gliptin. So I personally feel with minimal drug interactions, any practitioner or nurse practitioner or pharmacist can give sitagliptin and combine it efficiently with a metformin or with a gliflozin efficiently. And I think that's the standard of care. So it clearly worldwide will replace with more accessible and affordable access now available for sitagliptin. It will clearly replace probably the sulfonylurea class of drugs because of the challenges which those drugs have. So I think we need to ensure that the sitagliptinization of the world will happen. Every day you will have one CME program with sitagliptin. I'm sure that somebody today morning put out that there is a pharmaceutical toxicity of sitagliptin. So I thought, better to have these slides. And but I must tell you only one thing, that it is the most evidence-based molecule on planet Earth in the gliptin class. The number of PubMed's citations on sitagliptin are the largest. They have done outcome data. They have done real-world data. They have done off-label data in every therapeutic space of diabetes. And clearly, it is a standard of care. So therefore, I think we have arrived here with sitagliptin to be there. And obviously, it will be now more affordable and accessible to a larger group of patients. So I don't think I want to dwell more into details. I had another slide kit, but many of those slides, Avdesh very beautifully and elegantly presented. So I cut out those slides, and I just thought that it is a hassle-free, easy to use meal-independent gliptin, truly once a day, with some very robust science and outcome data, much better than any other gliptin. And me and Avdesh can be challenged by all of you here if you feel that any other gliptin can come close to competing with that. I don't think there is some published data to compete with it. We are not talking of anecdotes. And clearly, Indians have a better response. There's very good data because we have a larger carbohydrate exposure. So there is published data now to show that Indians do better with the sitagliptin, truly once a day. Very good for the kidney. If you have, in absence of end-stage liver disease, it can be safely used. And again, as I said, minimal drug-to-drug interactions. Dr. Das, I think I'll stop here.
Thank you, Sasank.
I made it simple and sweet, and the guidelines have already got it. So a guideline slide I removed because of this, put it very nicely that it's standard of care, and even with the SGLT2 inhibitors with heart failure, it's again the standard of care. So ideally, we should have a combination where you will have a gliptin, an SGLT2 inhibitor, and maybe a metformin. And I think the time is not very far when we'll have this triple drug combination also available in India for our Indian patients.
Sasank, thank you very much. I think both of you have made the things very simple for the people to take home. A renal-friendly, hepatic-friendly, cardio-friendly, with a great glycemic efficacy comparable to gliflozins that of this beautifully showed, and ease of taking it once a day, meal independent. I can't describe the way you describe all the attributes of Sita and clearly put it in its clinical position in our country today. We'll have a very brief panel discussion. Now, without wasting any time, it's my great pleasure to invite Dr. Jabbar, PK. Can you just speak to us? Jabbar, the first question to you.
Good evening, Das sir.
Yeah.
My friend, Dr. Sasank Singhbhai. I'm extremely thankful to Micro for giving a platform to sit with the doyens in the field of diabetes. I think it's a very clearly discussed all the merits of sitagliptin or probably DPP4, and this Akasing's discussion was amazing. And he was looking into all the aspects of comparative studies between other molecules, and also it's marvelous. And regarding the sitagliptinization, I think that's a reality from today onwards because of many reasons. Dr. Sasank was discussing all the benefits. In addition to that, the bioequivalence also, I think, is well documented in our studies also. That is one of the merit of sitagliptin now. Now, people will come with a lot of papers and there is no bioequivalence, all those. It's not true. We have clearly documented bioequivalence in our clinical studies also. And all other merits, see efficacy pattern, especially Asia, you have very good reduction of glycosylated hemoglobin, weight neutrality, cardiovascular neutrality. There are a number of benefits have been clearly discussed and documented in the literature by various authors. I don't want to talk much. Over to Akadas.
Thank you, PK. I think you have wonderfully emphasized the friendliness of this molecule, and now it should be used universally. I just have a question now to ask to, I'll ask it to now Rajiv. Rajiv, how do you position the CETA plus dapagliflozin? As Rajiv, you are aware we're a little less of time. So I want you to the point, focus, but speak your heart out. Rajiv?
I think good evening, sir. Thanks a lot for this opportunity. Great pleasure to be part of Elliott group of physicians and panelists. Sir, I think Dr. Shashank has already very rightly positioned, so has been done by Dr. Avdesh also. Whenever we have a patient, all as per our own guidelines, RSSD, ASI, or any other international guideline, metformin has to be first-line therapy. All those patients, those who are exceedingly obese, those who have presence of atherosclerotic cardiovascular disease, those who have presence of diabetic nephropathy or heart failure, incipient or manifest, obviously will be the best candidate for next option will be after metformin will be either of these SGLT2, maybe say dapagliflozin. But for getting a good glycemic control, even in those patients, those who have established atherosclerotic cardiovascular disease or multiple CV risk factors, we are much wiser from TICO's data where we have found that sitagliptin is a standard of care either after metformin or after metformin SGLT2 inhibitor, just to not only get a significant amount of HUNC reduction, a significant post-renal reduction, especially in Indian and Asian patient, and it is also safe even if you have presence of diabetic nephropathy or multiple risk factors or even presence of non-manifest heart failure.
Great. I think Rajiv, I will ask a little corollary of this question to Avdesh. Avdesh, I mean, correct me when I'm going wrong. You know, in the hierarchy of entire oral antidiabetic drugs, if anything comes closer to oral semaglutide, it comes, I don't say the replace, comes in closure. Would you consider this as DPP4, I mean, CETA plus DAPA plus MET?
Well, so sir, of course, two drug would be perhaps better. So it's pointless to compare one tablet of oral semaglutide with two tablets of SGLT2 and DPP4. But I can tell you that even if you look into oral semaglutide, and if you see the SGLT2 head-to-head trial, one thing is pretty clear. There is no rocket science that oral semaglutide or GLP-1 agonist could be superior to a DPP-4 inhibitor, whether it is injectable and oral. By virtue of their mechanism of action, the GLP-1 would be powerful than a DPP-4 inhibitor. However, it's not very, clear or robust to suggest that even an oral semaglutide could be superior to a molecule like canagliflozin 300 milligram. They haven't done any head-to-head trial. Even if you look back to the Pioneer trials, in the Pioneer 2, they compared with empagliflozin 25 milligram. Although the oral semaglutide was superior in HbA1c lowering compared to IMPA 25, in the weight reduction endpoint, it was almost a draw. So therefore, and also please remember that it is the only trial, Pioneer trial, which was an open label trial. Why nobody did an open label trial while you are comparing with empagliflozin? You did 10 trials. Out of that, 9 was the blinded trial. Only one trial was the open label trial that was against empagliflozin. That was unfair means. So therefore, rather than challenging oral semaglutide with a tablet of SGLT2 and DPP4, I am still not convinced that oral semaglutide would be far superior to SGLT2.
Fantastic.
What is the combination?
Yeah. I think I wanted that answer, and this question stemmed from a great session that we had in Calcutta last week. And you remember, I mean, of course, Avdesh and Kalyan were the author of that session. We discussed it threadbare. But it shows the confidence limit of the people when they combine. I think I'm sure Srinath and the team will be bringing definitely this combination of sitagliptin plus of dapagliflozin. Both they have in their kitty now, and it will be a great. I mean, it will be giving a lot of things. At least 7 of the 8 amino octet at least, and as I rightly said, it can give a lot of things. I just want to ask you one thing. I think I'll ask this to Shashank. Shashank, I'm just changing the question that I've allotted to you. I just want to know that, in the eternity of diabetes treatment, Shashank, in the eternity of diabetes treatment, I consider 0.6, 0.8, 0.9 as a drug, as a reduction in H1C of a great value. You know, I think Avdesh didn't have the time to show glycemic efficacy, but glycemic efficacy, you know, David Nathan, I adore, he's my hero. You know, the way he has said, I mean, the glycemic efficacy is quite a bit. And in combination with metformin, it goes to 1.18, 1.18, almost 1.2. So, I mean, don't you consider that the that the glycemic efficacy is quite great?
So I'm sorry to disappoint you, Dr. Das.
Yes, tell me.
First thing is that in the Western world, gliptins were not popular drugs because of the 0.6, 0.8 A1C drop. They considered it as a very weak drug, and they never took off the way they took off. But the carbohydrate world of China, India, and rest of Asia, the drop of A1C was very, very robust. And the registration trial, which was done for Janumet, Dr. Mohan was the first author in the DRCP publication, showed that the A1C drop in Korea and India was more than 1%. That was basically indirectly attributed, not directly, to the higher exposure of the carbohydrates on the L cells of the intestine.
I think that's a great thing.
Are carb responsive because we eat more carbs. That's number one. Number two, the glycemic efficacy matters, but efficacy to efficacy, Avdesh very correctly said, almost all drugs are similar, but because it depends upon the baseline A1C. Higher the baseline A1C, the bigger the drop. However, when it comes to safety data, systematically done under an RCT environment or a real world environment, sitagliptin and its innovator took, and I agree with Avdesh that me and he have lectured across the world on this molecule, probably had the best data set in every space, in the evidence-based labeled space, which was in the label, and even in the off-label space. So you have data of sitagliptin just published in February on PCOS, where it has improved insulin resistance, because it also has an extra pancreatic action. It has an action on the muscle insulin resistance. With sitagliptin, they have discovered more and more things, but that is all anecdotal. That is all in small pieces of history. Dr. Satish Garg did a trial with type 1 diabetes, where he showed that the reactive hypoglycemia, or in type 1 diabetes, the hypoglycemia was lesser, but it was not statistically significant. So sitagliptin explored every indication which was possibly there on planet Earth. In the last 2 decades, before it got expired, the patent got expired, and I think it expires today or tomorrow.
Last evening.
It showed a path. And in our subjects like India or Southeast Asia or the Korean subjects, because we had a higher carbohydrate load, the efficacy was better. Having said that, there are other molecules which are equally good on efficacy. Because when a trial was done, and Dr. Arvind was one of the authors, which compared sitagliptin versus gliclazide, okay, the outcome was very different. So, you know, otherwise what will happen is tomorrow people will say, Dr. Avdesh, Dr. Shashank Doshi, Dr. Chawla, here you are talking of sitagliptin, tomorrow you are talking about gliclazide, and you are saying that that is having a better efficacy. You have to see the context, the baseline A1C, the duration of diabetes. Is it new onset? What is the duration? So you have to look at the patient as perspective. And remember, every type 2 diabetic is different. There is heterogeneity at the cluster. Secondly, at different durations of a diabetic's lifespan, the efficacy of the drug is different. So obviously, somebody who is newly diagnosed 6 months old in diabetes, their efficacy with sitagliptin. Then somebody is 10 years into diabetes, their efficacy with sitagliptin. Somebody 20 years on insulin, their efficacy with sitagliptin. Usually what sitagliptin has advantage is it has a very broad range of consistent efficacy across board in the evidence-based space. And that is what Avdesh did in the cardiovascular footprint very nicely. And it can synergize very well with SGLT2 inhibitors. Standard of care worldwide is SGLT2 inhibitors now. It's emerging as a standard of care. In that, a gliptin like sita and a metformin and or pio is emerging as a reasonable standard of care. And that's where I think it is right up there on the pecking order. Other gliptins don't come near sitagliptin in terms of evidence base.
Yeah.
Like for example, Abdesh very nicely said, the Saxa got blocked out.
Yeah, because of the heart failure data.
It only creates perception, but doesn't have hard data. And when it comes to other gliptins, they don't have any outcome.
I think great answer.
May I add one thing?
Yes, please.
Yeah, I think Dr. Shashank very rightly said in his own STAR study, they have shown that carbohydrate content in every diabetic patient in India, whether it is North Indian or Southern or Eastern or Western, is more than 66%. That is one thing. So overall, carbohydrate content in Asian or Indian diet is very high. Second important fact is we tend to have lean, thin, fat Indians, and we tend to have not only insulin resistance, but also significant amount of beta cell dysfunction also contributing towards that. So there also all gliptins for that matter. Of course, evidence with CETA is a great test, but all gliptins across the board have shown significant HbA1c reduction and postprandial reduction in Indian patient as compared to Caucasian patients. So I think that is how it becomes a standard.
I think Rajiv, exactly same point. I brought it up because the Americans. I mean, there are 3 areas at least where we have bet them. One is metformin. They use 50 years after us. Number 2, about the screening. We state screening starts at 35. They're doing it at 45. Then USPHS has brought it down to 33. Now, and third area, as Shashank rightly said, Americans, one type for the morning, one type for the evening, do consider possibly that gliptin do not work. But in Indian context, as both the speakers and Dr. Jabbar and you are beautifully shown, it's a molecule of the decade, which is beautiful. One question has been asked in the chat box, and I'll ask any one of you to answer. The questioner wants to know, can you use gliptin in cirrhotic diabetics? Anybody can answer. Builder definitely not. CETA has been liver friendly.
Frank,
Yes,
I would be
yes, Shashank, please.
With frank cirrhosis, I would be, with portal hypertension, I would be reluctant to use any gliptin for that matter. Or
better go for insulin. Better go for small dose.
I would mix and match. And in end-stage liver disease, one has to be cautious.
It is only clear till moderate hepatic insufficiency where you can use.
Sitagliptin is a good molecule for NASH, non-alcoholic fatty liver disease. Of course, it's not in the stage of cirrhotic. Because cirrhotic, you have only one molecule, that is insulin.
Moderate hepatic insufficiency.
Mild to moderate hepatic insufficiency, the label stops. In severe hepatic insufficiency, portal hypertension.
I think the answer. Thank you for giving the answer.
Sir.
Have the last word.
Yes. Of this.
Let me clarify further on cirrhosis is a very generalized word.
Yeah.
A cirrhotic patient needs to be decompensated then to use any DPP-4 inhibitor. So simply saying cirrhosis is not a contraindication to use DPP-4 inhibitor. As Dr. Chawla said and Shashank said, that you have to have a child category C, then it is contraindicated. Remember, all cirrhosis doesn't mean that it is child category C. So if you have got a decompensated liver disease based on several criteria, as you know, child's criteria, and if you are falling in class C, then you are not supposed to use any DPP-4 inhibitor. Up to child B, you are absolutely fine. But vildagliptin is never used in any degree of hepatic insufficiency.
Thank you for the answer. Now, there is one question which is little basic, but since the questioner has put it in the chat box, I like to ask. The question is correct. He says, since sitagliptin addresses DPP-4, it is possibly best in class than the others which address DPP-8 or DPP-9. I mean, the enzyme 8 and 9. Of this, your opinion on this?
Well, so see, all of these DPP-4 inhibitors, which has been given US FDA approval, are largely a selective DPP-4 inhibitor. Of course, they differ in selectivity versus DPP-4 against other DPP substrate like DPP-8 and 9. So in the class, not necessarily sitagliptin is most selective. Even linagliptin, allogliptin is equally selective or perhaps more than sitagliptin. But see, these 3 DPP-4 inhibitor, allo, linagliptin and sitagliptin are highly selective DPP-4 inhibitor. The least selective DPP-4 inhibitor is vildagliptin and immediately followed by saxagliptin. So if you have to ask me the order of DPP-4 inhibitor in terms of their selectivity to DPP-4 versus other enzymes like DPP-8 and 9, I would start from the list rather than from the top, because in the top list, they all are pretty similar. Lina, allo, and sitagliptin are pretty similar. In the lowest rank lies with the vildagliptin, and therefore the skin side effects are the highest with vildagliptin compared to all other DPP-4 inhibitors. That was another reason, apart from the hepatic dysfunction, as Sasank told you, that the Novartis applied for 3 times. Remember, even Galvus was asked for US FDA approval before Januvia, but till date they never got the US FDA approval. Why? There were 3 reasons behind that. One was the hepatic dysfunction. Another was the selectivity, which led to the highest number of skin reactions with vildagliptin. And third was the metabolites of vildagliptin in CKD patient. Today, if you go to the Twitter, Daniel Drucker has posted why vildagliptin was not given approval was one reason, that there is a toxic metabolite in the vildagliptin in patients with CKD that was found in a rat experimental study. So therefore, the selectivity also matters because your patient perhaps could be on a longer period of time with a DPP-4 inhibitor, and you don't want to use any drug which has got an off-target side effect. We never knew what these off-target side effects could lead to. And therefore, when you have got all the drugs with a super selective DPP-4 inhibitor, I would not be preferring using a non-selective DPP-4. Lastly, sexagliptin, that is in the second last list in the DPP-4 selectivity. If you look the sexagliptin, their PA suggests that sexagliptin causes reduction in WBC, lymphocyte count, lymphopenia. And that was also one reason cited because of increase in heart failure in the SABRE-TV trial, that whether selectivity was one reason, because DPP-9 is present in aortic blood vessel that could lead to increase in heart failure. So these were propositions. We don't know exactly the reason behind that. But of course, if you would like to use a selective DPP-4 inhibitor.
Thank you, dear friends. Now it is going to be 8:28. And every good thing has to come to an end. But I must tell you today, I'm delighted beyond measure the way all of you, Professor Jabbar, Professor Chawla, Shashank, and of this, you have discussed threadbare and put the sitagliptin in the pedestal it deserves. But before ending, I must ask a last parting message from all of you. I'll start with Jabbar again. Jabbar, 1 sentence or 2 sentences as a parting message before we go for the lunch of this.
From today onwards, we are going for sitagliptinization. That's
Good.
it.
Thank you. Rajiv, your take home?
I think in this era of SGLT2 inhibitors, still gliptins are standard of care. Shashank very rightly put it and positioned it that there is a huge evidence on sitagliptin, not only in terms of cardiovascular safety, in terms of renal efficacy, and also to till moderate hepatic insufficiency. So even if you have already a good glycemic control and patient is already on SGLT2 and metformin, still gliptin remains the standard of care. But one thing I like to caution, everything what we are extrapolating for sitagliptin is based on an innovator. I think we have to have a lot of pharmacovigilance. We have to have that every company has a PKPD which will match the innovator, what we had the qualities in Januvia. So till we have some data coming on that, we should not be straightway extrapolating all the benefits to the generics which are getting launched today.
I think
more than 100 brands have been launched, but I think we have to see that at least good quality brands, they must match PKPD.
Absolutely. I think Rajiv, the last word that we discussed in Calcutta was that we remember of this. We requested that we must do the research and bring our own molecules DPDT data, because that is vital to our country's existence. Absolutely same thing we have said today. And at the same time also, let us also try to bring some innovative molecule. That's also my appeal. People have done wonders. So we can bring innovative molecules, and these molecules when introduced, we might have farm data. Now, comment from Shashank, 1 sentence from you.
I think I'll echo what Jabbar said. It's sitagliptinization, which we'll see. And it is standard of care. It is more affordable, more accessible. Absolutely. So I wish it translates that more people get benefit of sitagliptin in a larger population of the Indian soil, because we have around 72 million diabetics with type 2 diabetes in India. And I am even now told that less than 10% of them are actually benefited through a gliptin class. So I think that percentage really needs to improve. And I think if that access and affordability is there, and I completely echo with what Rajiv said, and I'm sure Avdesh will agree that we need bioequivalent, bioavailable, quality should never be compromised when it comes to affordable access. But sitagliptin is standard of care with metformin, and I think it was always there for the last 2 decades. I only wish and hope that larger number of people across India, because of its affordable and accessible nature, will have benefit from the molecule.
Thank you. Of this, one sentence from you.
I have nothing to say here. I have already shown the data. Sitagliptin was at the top, and Microlabs knows that I was never associated with them when it comes to other DPP-4 inhibitor. I am back here with them because they brought the molecule, which was our choice always. The only point I would always ask before I put my pen down to prescribe sitagliptin for any Indian pharma company is to show me a bioavailability data. I would be happy. It is a very close group, and it's a very close group. And may I request Mr. Srinath or anyone from Microlabs to show me here upfront that do you have a bioavailability data? I know no one has got a published data, but even you have got a data on file. I would believe you. Please show us the bioavailability.
Yes, sir.
Before I'm going to prescribe a single prescription from tomorrow onward.
Then we have to do it very fast.
I think Dr. Manjula did mention to me. Yeah. Manjula is the medical affairs chief. Manjula, will you like to show it now, or will you show it little later? But of this, I have not seen the data myself. But she did discuss with me some time back when this molecule was being brought in, and I think Dr. Manjula, the medical in charge, will be able to show some data in the course of the time today or little later. But that is vital. Dear friends, before I hand it over to for the formal lunch, I must tell you that this evening has been a great evening, packed with knowledge, clinical practical issues of a molecule. And I will end by a simple sentence. So all of you have mentioned, even of this, Rajiv, you know, we lost Professor R.D. Lele some time back. He has been hailed in the Avdesh, who saw that write-up we had when Shashank wrote, teacher of the teachers, and, you know, unforgettable part of all the meetings. Once he called me in Bombay and he told me, Avdesh, that Ashok, you know, South Africa prepared anti-HIV drugs. You know, it was long back, Avdesh, almost about 12 years back, 12, 13 years back. Now we are not able to get gliptins. You know, and he was so convinced about the utility of gliptins that he said, can't we do something with the government of India, because we will take a long time to manufacture. Dear friends, today we have the best of the gliptins in our hands. I hope, and I'm absolutely confident, they have to give us the data, its bioequivalence and the studies. But this gliptin, which is the best in class, which has become, as you rightly discussed in the very beginning, 4As, very affordable. Of course, it is appropriate, as you saw the sea of data, the great data presented today, and also it is available and accessible. It is going to be the molecule, the gliptin molecule of the decade. With that, may I now hand it over for the lunch to Srinathji and Nagaraji, please.
Doctor, first of all, thank you so much for the intense deliberation on sitagliptin. I think, in all the aspects, it has been proven that this molecule is one of the best gliptin among the entire DP4 inhibitors. Yeah. And thank you so much. And as suggested by all the eminent KOLs on this platform, that it's a time for us to go for the sitagliptinization. That's what is more appropriate now. The one challenge was there, of course, the affordability and accessibility. Now, I think it's every deserving patients can go for this sitagliptin. As mentioned by all the doctors, that in terms of PKPD, certainly, sir, we will provide you the data very shortly.
That's
Yeah, and we take this opportunity and we take this platform to unveil our brand, because Microlab is known for coming out with a quality drug with affordable price, and we take this opportunity to unveil the brand in front of all the eminent KOLs as well as across the country, the doctors who are watching this. So with your permissions, I request Mayank to display the brand launch.
10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Thank you very much. And it's my great pleasure and honor to thank Avdesh, to thank Shashank, thank Rajiv, and thank my dear friend, Dr. Jabbar, for the great participation, great science, great inspiration, and great practical clinical way they presented. I mean, it's called practice change. Their talks on practice change. AK, thank you very much. Shashank, again, thank you very much. Rajiv, thank you very much. And PK Jabbar, sir, thank you very much. My thanks to of course, to Sinadji and Nagarajji for having given me this opportunity, to Dr. Manjula Suresh, and the request that we would like to see these things that we discussed here. And I'm extremely grateful to the great audience who have joined today. Thousands have joined, I'm just told by Hardik, and I really congratulate them, and I'm grateful to all the people who have joined us today. I knew we had other choices, and your presence have made our evening. Thank you very much for joining us. On behalf of, not behalf of me, Dr. Manjula, on behalf of all the speakers, all the experts, all of us together, we thank the audience because you were there, we exist. And thanks to Microlab, as usual, for giving us this great platform. Thank you, Sinadji. Thank you, Nagaraj.
Thank you very much,
madam. Thanks to entire team.
Thank you.
Thank you very much. I
Thank you.
exceeded
Thank you,
time
sir.
by 11 minutes. My apologies.
Thanks,
but,
Shashankji. Thanks,
the
Dr.
discussion was going on
Dr. Rajiv
so well.
Chawla. Thanks,
And
Dr. A.K. Singh.
I was telling that the things were so great. You know, it was flowing. And you know, if a speaker in assembly stops speaking, there are non-teaching teachers, non-operating surgeons. We're here, where is a moderator who wanted the people to speak, and we should benefit from the great presentation. Thank you very much. And in French, au revoir. Bye-bye. See you again tomorrow.
Thank you. Good night, everyone. Good night.
Doctor, I will not take much time. On behalf of Microlabs, I would like to thank our course director, Dr. A.K. Das, for designing this format of the scientific meeting, Sitagliptin Conclave. I think it came out extremely well. Thanks a lot, Doctor. I must mention our deep sense of appreciation to all our, the speakers, Dr. Shashank Joshi and Dr. Avdesh Kumar Singh and Dr. PK Jabbar and Dr. Rajiv Chawla for taking out your valuable time and giving your insights. I'm certainly this meeting would have brought newer insights and the new updates in the field of diabetes. Once again, we would like to thank the entire Microlabs team for making it happen. And we thank you for being with us today. I would like to thank all the doctors who are watching this.
Thank you.
And it has been a great pleasure. Thank you, doctor.
Bye. Good night.
Bye-bye. Good
Thank
night,
you. Thank
everyone.
you.
Good night.
Thank you, sir.
Good night, sir.
Good night.
Good night. Thank you. Bye-bye.
Bye-bye, Santosh. Bye.
Bye.
Thank you, sir. Thank you.
Thank you, sir.
Thank you, madam.
Thank you very much. Thank you, everyone. Congratulations.
Thank you, madam. Thank you, madam.
Great.
Thanks, ma'am.
Thanks, Srinath sir, and thanks Mr. Gokul and Sarangi and Mr. Murthy.
Yes, yes. Because of them, so many attendees.
Exactly. I think it was a wonderful
Gathering of faculty, madam.
Wonderful, na sir. Went off really well. Great. Are we live still?
I don't think so, no?
Mayank,
Yeah, we are live.
Yes.
so we can, I think,
Thank you.
officially we can close the meeting.
Yeah. Thank you, madam.
Srinath sir, thank you. Boss,
I should thank you. Wonderfully done,
Boss.
Nagaraj.
thanks a
You're-
lot, boss.
you're
Very
doing-
good, sir. Went off well.
Yes, madam.
Nagaraj, thank you. Gokul.
Yes, madam.
I think we
I
are
don't know
still.
whether Gokul is there online. I don't know.
RX event, can you make offline? We are still live. I think that we can end the meeting, please.
Mayank, still,
Yes, sir.
yes, Mayank.
Tech
Are
team
we
is
live?
host.
Are we offline? Are we on
Tech-
offline?
No, we are online. Tech
That's
team
it,
is the host, so
Oh.
they will help you.
Okay. So I think, ma'am, then
Okay, we leave. Bye
Yes,
then.
Yes,
Bye,
ma'am.
sir. Good evening, sir. Good
evening.
night, sir.
Thank you.
Gokul, bye. Bye, Kale,
Thank you.
all everyone. Bye. Bye.
I think, Mayank, you can officially close the meeting. Yeah.
Nagaraj, 1 minute. 1 minute.